I am Dr. Sharjeel and you are watching my YouTube channel. If you like my videos, don't forget to subscribe my channel. Now today's I'm presenting an interesting case. This 70 years old female presented with painful decrease of vision along with severe headache on the same side, nausea, vomiting and red eye. Her vision was hand movements and on slit lamp examination you can see there is a corneal edema, AC filled with milky whitish material, and pupil and posterior segmented details are not visible. When I measured her intraocular pressure in this eye was 40 millimeter of mercury, whereas the other eye had deep anterior chamber, open angle ongonioscopy, pseudophakia and healthy fundus with cup disc ratio of 0.4. So I diagnosed her as a case of phacolytic glaucoma, which is a type of secondary open angle glaucoma associated with a hypermature cataract. As we all know that lens produce fibers throughout the life from birth till death, and there is a no excretory mechanism of the lens, so the lens proteins are accumulated within the capsule throughout life. So a time comes when the lens transparency is lost and the lens becomes opaque or cataractous. Then it becomes mature. A time comes when it becomes hyper mature, and then a stage comes when the lens capsule is no longer able to hold all the material. So high molecular weight lens proteins then leak through intact capsule and fill the anterior chamber along with the macrophages, giving a milky appearance to the aqueous, as you can see in this a classical case of phacolytic glaucoma. As the only route outside of the anterior chamber is through trabecular meshwork, so the aqueous pores of the trabecular meshwork are clogged by these high molecular weight lens proteins and macrophages, leading to very high intraocular pressure. Like in this case it was 40 millimeter of mercury. As treatment of all lens induced glaucomas is lens removal, in phacolytic glaucoma you have to remove the lens to treat it, but first you have to decrease the IOP medically by topical anti-glaucoma drugs, specifically beta blockers and carbonic anhydrase inhibitors topically, as well as systemic acetazolamide is given, brimonidine and osmotic diuretics like mannitol is given, and topical steroids as well, because inflammation is a key factor in phacolytic glaucoma. Then we proceed towards the cataract surgery. Differential diagnoses are phacomorphic glaucoma, but the difference is that the anterior chamber will be shallow and there will be intact lens matter, intact capsule, and the lens matter will not leak through in phacomorphic glaucoma, so AC details will be a bit more visible, and the other eye may have a shallow anterior chamber as well. Then traumatic cataract with ruptured anterior capsule can give you the same picture, but then there will be an obvious history of trauma. Acute anterior uveitis can fill the anterior chamber with haze, but that will not have a milky appearance, and there will be photophobia and all other signs of pure uveitis. Stromal keratitis can sometimes be confused with phacolytic glaucoma, but then anterior chamber and rest of the eye will be normal. So these are the differentials.